we will be discussing about the blood supply of the brain and the spinal cord. When you consider the blood supply of the brain, there are two pairs of arteries that supply the brain. There is what you call an anterior circulation and a posterior circulation. Now, the artery responsible for anterior circulation is the internal carotid artery. So there are left and right internal carotid arteries. Then the arteries responsible for the posterior circulation are the two vertebral arteries. So that is the basic thing. So you get the internal carotid arteries like this, left and right internal carotid arteries, and they give what is called the middle cerebral arteries and anterior cerebral arteries and a posterior communicating artery like that. So then the two anterior cerebral arteries from the two sides, they go like this, and there is a communicating artery between the two anterior cerebral arteries, which is called the anterior communicating artery. Then the posterior circulation, you get the two vertebral arteries coming like this. You know how they come. They come through the intervertebral foramina, and they enter the cranial cavity after passing through the posterior atlanto-occipital membrane. And these vertebral arteries, they form one artery which is called the basilar artery, and that one gives the posterior cerebral arteries like this, and this posterior communicating artery communicates with the posterior cerebral arteries. So that's how you have a circle of arteries here. We will discuss that later. Anyway, so you have an anterior circulation which is fed by the internal carotid arteries, and posterior circulation fed by the two vertebral arteries. And these arteries, by now you already know that these arteries lie in the subarachnoid space. And I'll show you next slide. And the branches anastomose to form the circle of Willis, which I just showed you. And once the okay, I'll show you with this one. Now here is your the two vertebral arteries. The two vertebral arteries coming through the intervertebral foramina and uniting to form the basilar artery. Okay, and this is how the vertebral arteries enter the subarachnoid space. This is your occiput, and this is your atlas vertebra. This is the posterior arch of the atlas here. Posterior arch of the atlas, you know that. This is the posterior atlanto-occipital membrane between the posterior arch of the atlas and the border of the foramen magnum. So this is the vertebral artery passing into the cranial cavity through that. So then it forms the basilar artery, as you can see here. Then it gives the posterior. There are two arteries given off actually. There is a superior cerebellar artery and a posterior cerebral artery. So this one is the posterior cerebral artery. So the previous one is the superior cerebellar artery. We will discuss that later. So you have your the internal carotid artery giving rise to the middle cerebral, and so this is your internal carotid giving rise to middle cerebral, anterior cerebral, and anterior communicating and posterior communicating. So that is how the circle of Willis is formed. Now this point about where the blood vessels are, they lie in the subarachnoid space, as we said before, and therefore they are bathed in cerebrospinal fluid, because this is the same space that contains cerebrospinal fluid. And the blood vessels that are there in the subarachnoid space, they send branches into the substance of the brain, as you can see here. Now inside the subarachnoid space, as you saw in the previous part of the discussion, there are free anastomoses like in the circle of Willis. But once the branches leave the subarachnoid space and enter the brain substance, then they do not have branch, they do not have collateral circulation, so they do not have anastomosis, and therefore they act as end arteries. Okay, they are almost end arteries and if you occlude some of these branches, then the area supplied by that branch will have ischemia, lack of blood supply, and die. So that is the case. That's why you get strokes and all. When it comes to this where you get this collateral circulation, anastomosis, the usual rule is if you get blood from the vertebral arteries, they go through the posterior cerebral arteries like this. Whatever that comes to the carotid arteries go through its branches. So there is no mix up of maybe on the next slide would be better. Yeah. So if you get blood from here, from this side, posterior ones, they will go through these branches. Whatever you get through the internal carotid will go through the middle cerebral, anterior cerebral, like that, rather than blood passing this way or that way. Here also, blood usually does not pass across each side unless one side is blocked. Unless one side is blocked, blood will not pass through these communicating arteries, this one and this one. Okay, but if you block one side, say you block this side, total block of this side, then blood will pass from the posterior cerebral to the middle cerebral, so the other way. Okay, so if you block this somewhere here, you will get blood going that way. Okay, or whatever, wherever you block, then the blood can go through these collateral circulations. Otherwise there is no mixing up of blood, even though there is a circle like that. Okay, so this circle of Willis, I will do it now in detail. You have the vertebral arteries coming through the intervertebral foramina, and as I said before, passing through the posterior atlanto-occipital membrane and entering into the subarachnoid space. And then if you draw the brain in this background, you will have your pons in that area where you get the basilar artery. Okay, so the basilar artery lies in front of the pons. Actually there is a groove, basilar groove in front of the pons for the basilar artery, and that's why you get these pontine branches supplying the pons. Okay, so even though the brain is not there, understand it like this. This is the area of the pons. Okay, and this is therefore the area of the brain, the medulla, area of the medulla. Okay, and if you have the pons here, then you have the cerebellum also in this area. So if you look at this, you can see the basilar artery, this one, ends by dividing into two posterior cerebral arteries. Two posterior cerebral arteries which are part of the blood supply of the brain and part of the circle of Willis, therefore. And before that you see the superior cerebellar artery here. Superior cerebellar artery, and before the pontine arteries, actually before the beginning of the pons is somewhere here, or at the beginning of the pons, you have anterior inferior cerebellar artery. Okay, and further even before the basilar artery is formed, you get the posterior inferior cerebellar artery. There is an anterior inferior cerebellar artery and posterior inferior cerebellar arteries. The superior cerebellar, anterior inferior cerebellar, and posterior inferior cerebellar, they all supply the cerebellum, and some of them supply the brainstem, either pons or medulla, which is clinically very important. Then if you look at the anterior circulation, you have the internal carotid here, as I said before, forming the middle cerebral, anterior cerebral, and giving the posterior communicating branch to communicate with the posterior cerebral artery. And the two anterior cerebral arteries, they have an anterior communicating artery there. Anterior communicating artery there. The anterior cerebral artery passes, if you have your corpus callosum like this, the anterior cerebral artery pass over the corpus callosum like this in a medial view. So your cingulate gyrus would be in that area. So those areas are supplied by the anterior cerebral artery. We'll take a look at that. So these are the things that I wanted to express here. Then there's another point. You can see the vertebral arteries, before they unite and form the basilar artery, there is another peculiar formation of an artery. Two branches from the two vertebral arteries unite and join and form one artery, which is called the anterior spinal artery. So when we look at the blood supply of the spinal cord, anterior spinal artery becomes an important artery. Okay, anterior spinal artery. With that, we'll move on to the next slide. Now this slide shows you few important branches. Now this is your vertebral artery here, left vertebral artery, and the right side vertebral artery you can't see in this one, but you can see the basilar artery here. Okay, so that is basilar artery in front of the pons here in the basilar groove, and this is your medulla, this is your cerebellum. Okay, so get yourself oriented now. Okay, now the basilar artery gives superior cerebellar artery. You can see the superior cerebellar artery here, supplying the superior surface of the cerebellum, and this is the posterior cerebral artery, which is the final branch of the basilar artery. So you can see actually from the posterior cerebral artery, branches are going into, now this is the choroid plexus of the lateral ventricle. Branches are given to the choroid plexus of the lateral ventricle, and of course the third ventricle also here, which is not shown here as a diagram, but they give actually, posterior cerebral artery gives branches to the choroid plexus of the lateral ventricles and third ventricle. So that is also important. Superior cerebellum supplies the superior surface of the cerebellum, and this is this anterior inferior cerebellar artery, and this is posterior inferior cerebellar artery. Okay, now these arteries, you can see both anterior inferior cerebellar and posterior inferior cerebellar arteries, they supply the inferior surface of the cerebellum. Okay, then at the same time, the posterior inferior cerebellar artery is more important because it's clinical. There's a clinical importance here. When it passes lateral to the medulla here, see the lateral aspect of the medulla, it supplies the lateral aspect of the medulla as well. So when this artery is occluded, posterior inferior cerebellar artery, you get a condition called lateral medullary syndrome. We will discuss what is lateral medullary syndrome and the signs of lateral medullary, symptoms and signs of lateral medullary syndrome in relation to the posterior inferior cerebellar artery. Why you call this superior cerebellar artery? I think you can understand it because it supplies the superior surface of the cerebellum. Now these two arteries, why they are called anterior inferior and posterior inferior? Because this both supply the inferior surface of the cerebellum. When you look at the origin of the artery, this is at an anterior position than this one. This is at a posterior position. This is at an anterior position. Anterior inferior and posterior inferior. Then you can also see the internal carotid artery in this diagram. This is the internal carotid artery, the anterior circulation, passing through the carotid canal here. You can see the carotid canal here. Okay, it passes through the carotid canal, and it passes through the cavernous sinus also somewhere here, and then it gives off the middle cerebral artery and anterior cerebral artery. Okay, and here this is your corpus callosum. This is the rostrum of the corpus callosum, anterior end. You can see the two anterior cerebral arteries lying very close to the rostrum of the corpus callosum. Then they go like this. Okay, supplying the medial aspect of the upper part of the brain. And you can also see branches of the posterior cerebral artery here supplying the occipital lobe of the cerebral hemisphere. Occipital lobe of the cerebral hemisphere. Now we will go into the details of blood supply of the brain. Now you have three main arteries. By now you know that from the circle of Willis you get the anterior cerebral, the middle cerebral, and the posterior cerebral arteries. As you can see in this diagram, anterior cerebral is indicated by blue color, the middle cerebral in red color, and the posterior cerebral in green color. Now this shows the lateral aspect, and this shows the medial aspect of the cerebral hemisphere. So that you can get an idea about the extent of the brain supplied by each of these three arteries, but sometimes that is not enough because you don't get an idea about the depth. Now this does not give an idea about the depth of supply, it only gives the surface. So this diagram, this is the horizontal section of the brain, which shows this is the typical horizontal section of the brain. Usually, you know, when you're asked to draw the horizontal section of the brain, this is the section that you draw usually, because that shows you all the important structures within the substance of the brain, like the lentiform nucleus here, the head of the caudate nucleus here with the anterior horns of lateral ventricles, and the thalami, the fourth ventricle here, or the third ventricle here, and the most importantly, the internal capsule. And even the corpus callosum, rostrum here, and the splenium here. So this is an important diagram. So according to this diagram, actually the anterior cerebral arteries will pass through that area, okay, in relation to the corpus callosum part here, and the depth of their supply can be shown like this. Now the middle cerebral, it passes inside this lateral sulcus, okay, inside this lateral sulcus, and gives branches to this middle part. So as you can see in the first diagram, if you compare it with the first two diagrams, this one and this one, compare this the horizontal section with the previous two diagrams, you can see the depth of supply of each of these arteries: anterior cerebral, middle cerebral, and the posterior cerebral arteries. Okay, and the middle part where the internal capsule, the lentiform nucleus and caudate lies, actually that area is supplied by mainly by both anterior and middle cerebral arteries. Even, you know, if you see the description of the posterior cerebral, that can even actually supply, that also can contribute to supply the lentiform nucleus, but you know, we can't remember all that stuff, but get an idea about, this is a rough way in which you can remember the blood supply of these three arteries. Now you come back to the first diagram again, this one, you can see that the anterior cerebral supplies the inferior surface of the frontal lobe, and here the medial, this is the medial aspect of the frontal lobe supplied, the whole medial aspect is supplied by the anterior cerebral artery, and on the lateral surface you see a strip, only a strip of the frontal lobe is supplied by the anterior cerebral artery. Then even in the parietal lobe again you see another strip supplied by the anterior cerebral artery. Then the rest of the frontal lobe here, and the rest of the parietal lobe, and the upper two gyri, superior and middle temporal gyri of the temporal lobe, are all supplied by the middle cerebral artery on the lateral surface. On the medial surface, very little area in the temporal lobe is supplied by the middle cerebral. It's largely supplied by the anterior cerebral, and the posterior part, the occipital lobe, small strip of parietal lobe is supplied by the posterior cerebral artery. So the visual cortex, the calcarine sulcus, this is the calcarine sulcus, on either side of it you get the visual area. So that area is totally supplied by the posterior cerebral artery. So if you obstruct the posterior cerebral artery, obviously there will be the opposite visual field will get affected. Okay. On the other hand, if you block anterior cerebral artery or the middle cerebral artery, you will get effects on the mainly on the internal capsule and basal ganglia of that area, other than its supply to this surface, because this surface is important because you get the premotor cortex here, which is the that is the primary motor cortex, and this is the primary sensory cortex. So you can see this area, if you look at the homunculus, that area is the lower limb area. So that area would be affected if you damage or block the anterior cerebral artery. Then the upper limb and the face area will be affected if you block the middle cerebral artery. Okay. So you block the posterior cerebral, you get visual effects. You block anterior cerebral, you get lower limb, perineum, you know, that area effects. You block middle cerebral, you get upper limb, face, and more than that, if you block the middle cerebral artery, you know that in this area you get the motor speech area, which is called the Broca area, that is in the frontal lobe, inferior frontal gyrus. Then you get this area you get the sensory speech area. By now you must have learned in physiology, which is called the Wernicke's area. So both these areas, motor area, motor speech and sensory speech areas are supplied by the middle cerebral artery. So if you block the whole middle cerebral artery, the effect would be huge. Okay, not only in the internal capsule but on the cortical areas as well. So this is all regarding this diagram. Then okay, so this, when you have time, you can go through this description that I have written here. I have listed out the areas supplied by these arteries: anterior cerebral artery, middle cerebral artery and posterior cerebral artery. By no means this is a complete description. You can read out textbooks, but at the same time remember that you cannot remember all minor details, so you have to have some way of remembering things also. So make them simplified and then try to understand them. So this is the point that I told you about the homunculus, both motor and sensory homunculus. You have both in this diagram. You know what is homunculus. It's the upside down representation of the body in the primary motor and sensory cortices, which you can see here. So based on this diagram, if this area roughly, if this area is supplied by the anterior cerebral artery, then you can clearly understand that the effects would be on the perineal area and the lower limb area. Similarly, if that area is supplied by the middle cerebral, effect would be on the upper limb, mainly hand and the face area. So the posterior cerebral artery will not have an effect on the homunculus, the pre and post central gyri, because that is on the posterior side, on that side. It's the visual effects you get with that one. So this is a diagram I got from some textbook. This is the middle cerebral artery. This is the left middle cerebral artery in the lateral sulcus. You can see how it supplies these internal structures that I tried to show you on the horizontal section that I drew. You can see these two important groups of arteries: medial striate arteries and lateral striate arteries. Now usually when you get strokes, you know what are strokes? You get a blood clot blocking one of these arteries, or you get sometimes bleeding from one of these arteries. It is usually not the main artery that gets affected in strokes, but these medial or lateral striate arteries. Okay, so if you say block one of, or several of these arteries, you get effects on the internal capsule. Okay, so depending on the block, the area supplied by the blocked artery, there can be various, there can be varying degree of defect. Okay, loss of function. Remember these two terms: lateral striate arteries and medial striate arteries of the middle cerebral artery. They are the ones that supply the internal capsule, lentiform and caudate nuclei in that area. Then when it comes to the blood supply of the internal capsule, by now you know the different nerve tracts that are passing through the internal capsule. Again, there are complicated ways in which you describe it. In general, how I remember it is that you have the this fibers starting from frontal and temporal lobes, frontoponto and temporoponto fibers in that area. Some sensory fibers are also there according to the diagrams. But the most important thing is in the genu area, you get all your corticobulbar fibers, the cranial nerve, upper motor neurons of cranial nerve starting from the cerebral cortex, passing through the genu. Then the anterior part of the anterior limb, the posterior limb, anterior part of the anterior limb, you get the corticospinal tracts. Okay, tracts going down, motor tracts going down into the trunk and the limbs. Then behind that you get the thalamo, the spinothalamic tract. Whatever, you get the ascending nerve tracts or sensory nerve tracts. Then your visual and auditory ones lie further behind, which are called retrolentiform part of the nucleus. So that is the general arrangement of fibers, but I know it's more complicated than that. Okay, you can divide this into areas like this, that way, and then you can describe it. Okay, but having a rough idea is better than not remembering anything. Now, when you look at this, you can see that the internal capsule has been divided into an upper part here and a lower part, upper half and a lower half, on top of anterior, posterior limbs and the genu. The whole thing is divided into an anterior half and a posterior half, and the whole upper half, whole thing is divided into superior and inferior half, and the whole superior part is supplied by the medial and lateral striate arteries of the middle cerebral artery, as I told you before. Then the inferior half of the internal capsule, the anterior limb is supplied by the anterior cerebral artery. Then the genu area is supplied by branches of the posterior communicating artery, and the posterior limb is supplied by the anterior branches of the anterior choroidal artery. And this is not a complete list, okay? So I'm just handling the main arteries here. Now the important point that you should remember by looking at this diagram is that the medial and lateral striate branches of the middle cerebral artery is so important when it comes to the supply of the internal capsule, because it supplies all areas of the internal capsule. And on the other hand, it's not alone. That is also important. Even if you block the middle cerebral artery, the whole middle cerebral artery, and then there will be no blood in all medial and lateral striate arteries, still some of the nerve tracts passing through the internal capsule may be spared because of this other artery supplying it. On the other hand, if you block one of these arteries, anterior cerebral or posterior communicating, then again depending on the area supplied by it can vary in different people. You will not get a complete loss of any of these limbs. Okay, but at the same time, remember this diagram also, which is 3D, lateral view of the same thing. This same thing has been drawn here also from a lateral view, seen from the side like this. Your eye is from that side. Here it's very nicely put. You see the anterior limb and the genu here, and the posterior limb in that part, and the retrolateral part, which is auditory and visual. Here you can see very nicely, this is the area supplied, the internal capsule supplied by the middle cerebral artery, medial and lateral striate branches, and the area supplied by the anterior cerebral artery. Okay, just compare with this one. Okay, and then the genu area supplied by the lower part, inferior part, by the posterior communicating artery, and then the anterior choroidal artery supplying the lower part of the posterior limb here. Okay, so this is a very nice diagram. Okay, but you might not be able to remember it exactly this way, but have some mechanism to remember that these, at least remember that these branches are important. If somebody says, say, MCQ, internal capsule is supplied by middle cerebral, anterior cerebral, posterior communicating, anterior choroidal, all correct. Okay, they have some sort of supply to the internal capsule. The most important supply comes from the middle cerebral. That's the point that I wanted to raise here. Okay, then we'll take a look at the effect of cerebral artery occlusion. Now again, this is by no means a complete list of symptoms and signs. I'm just going to show you some way of working out it. But only thing is, I cannot ask you questions. You are silent. I will show this and I will give the answer also. Otherwise, I would be able to ask you in a normal, usual setup. I will ask you and get the answer from you. Now, if you get hemiparesis, weakness of right lower limb with exaggerated reflexes. Now, exaggerated reflexes are there when you get upper motor neuron type of lesion. Okay, especially when the pyramidal tracts, which are starting from the premotor, precentral gyrus, primary motor cortex, you get exaggerated reflexes. So you have paralysis, or hemiparesis rather, right lower limb and exaggerated reflexes. Okay, and sensory deficit in the right lower limb and perineum. So you have a sensory deficit as well as motor deficit with exaggerated reflexes, which indicates upper motor neuron lesion. Then anosmia is absence of smell sensation, and the personality changes with urinary incontinence. Now, this anosmia, the moment you see anosmia, that shows the inferior surface of the frontal lobe, because that area where you get the olfactory bulb and olfactory tract, even though there is no specific area, the inferior surface of the frontal lobe is responsible for smell, at least partly. Then this personality changes and urinary incontinence is well known for frontal lobe lesions. If you get frontal lobe tumors, you get urinary incontinence and personality changes. So this indicates the frontal lobe again. And apraxia. Apraxia is the inability to perform learned or familiar movements. Now, there are certain things that you learn over a period of time, and when you get damage to the frontal lobes, you get apraxia. Now, the area of the frontal lobe that is damaged is the supplementary motor area, which is, if this is your central sulcus and this is your primary motor cortex and this is your sensory cortex, this motor supplementary area is in front of the primary motor cortex. Now that area, when damaged, then you get this apraxia, inability to perform learned movements. You might understand, if someone else tells you to do something, you might understand the command and you actually want to do it. Okay, you want to respond to that person and do it, but you cannot initiate the movement. So that is apraxia. So all these things taken together, that actually you cannot explain it with the lesion of the spinal cord, of course, because in a spinal cord lesion you will never get these things. Okay, they are all indicating that it's not a spinal cord lesion. It's definitely a cerebral lesion. So that's one point that you have to remember. Then the other thing is, on top of that, if you have right side of the lower limbs weakness as well as sensory loss, okay, weakness as well as sensory loss, then again it indicates together, when you have these two with exaggerated reflexes, it indicates clearly not something from the cerebellum, not something in the spinal cord or internal capsule, but at the cortical level. Okay, so then it's pretty clear that this is the left anterior cerebral artery occlusion. Okay, now you remember the diagram always. Now this is your brain. Anterior cerebral artery will supply on the lateral surface an area like this. Okay, not so long, an area like this. Okay, and on the medial surface it would be a fairly large area. So you get this lower limb defects, upper limbs and face are spared. Then another case where you get weakness of the lower half of the right side of the face, weakness of the right upper and lower limbs. Here again you have the lower limbs, but it doesn't specify whether the weakness is more or less in the foot area or thigh area. It's like that. Then the sensory deficit of the right side of the face and upper and lower limbs. Again, motor and sensory going together here. Then the limb reflexes are exaggerated, so it indicates upper motor neuron and aphasia. The moment you see aphasia, you know it's a cortical issue. Okay, so this aphasia can be either, the lesion can be in the Broca area or in the Wernicke area or both, because you have a sensory speech area and motor speech area. So you can have motor aphasia or sensory aphasia. So aphasia means either or both of them. Okay, and weakness of limbs, weakness of right upper and lower limbs both is indicative of, it can be caused by a cortical lesion as well as by an internal capsule lesion. Then the weakness of the lower half of the right side of the face. Weakness of the lower half of the face, I think we haven't done cranial nerves yet. If you draw your face like this, and if you draw a line here along the angles of the eye, this is your forehead area. Now, when you get lower motor neuron lesion, say if your right facial nerve, the lower motor neuron means the final common pathway that is starting from the final cell body in the spinal cord or brainstem. So if that nerve Oh, you call it facial nerve outside. That is your lower motor neuron. Okay, if the facial nerve is damaged outside, or anyway, it starts from the brainstem. We'll discuss that when we do the cranial nerves. That whole side would be gone. Okay, not only, now it says lower half of the right side of the face. Okay, it's not only the lower half. Okay, the whole half would be gone. Now what happens is when you have upper motor neuron lesions, you get only the lower half gone, not the upper half, because the upper halves of the face have bilateral supply from upper motor neurons of the cranial nerves. So both sides you get supply, okay, to this one. Therefore, if you damage one side, you will not get weakness of this side. Okay, so you only get the lower half of the face. Again, that indicates upper motor type of lesion. So it's got nothing to do with the cranial nerves or the facial nerve here. It's all upper part lesions. So, and this is right side, so the lesion should be on the left side of the cortical level of the brain. So you draw this, it's the middle cerebral artery. Okay, so this whole area would be supplied by the middle, this whole area would be supplied by the middle cerebral artery. That includes Broca area, Wernicke's area. Then you have your the face and hand area here. Lower limbs are over that area. So ideally the lower limbs should be spared if you just go by the cortical areas. But you cannot forget the fact that the internal capsule is also supplied by the branches, mainly supplied by the middle cerebral branches, medial and lateral striate arteries. Therefore, if the main artery, middle cerebral, is occluded before the striate arteries are given, obviously it's not only the cortical areas here, even the internal capsule can get affected. So the reason for weakness of both upper and lower limbs. Okay, if lower limbs were not there, you might describe it using only the cortical areas. Okay, so this is the middle cerebral artery occlusion typically. Okay, then if you get say visual defects, say left homonymous hemianopia and other visual defects, they can be caused by a pathway. If you have the optic nerves like this, then you have the crossing and you get the optic tracts like that. So even if you damage the optic tract, you get homonymous hemianopia, opposite side visual defect. Okay, so that type of things can be seen when you have posterior cerebral artery occlusion as well. Then you have to have, now this could be one thing. Then you have other features of posterior cerebral artery occlusion listed out to direct you towards the. Otherwise, it can be even, as I said, even the optic tract damage can give rise to the same thing. So the moment you have cortical symptoms and signs plus homonymous hemianopia, then think of the posterior cerebral artery occlusion. But always when you have homonymous hemianopia, don't go and say it's posterior cerebral artery. Okay, it can be even the optic tract, as I said before. Okay, so try to list out other things here. Try to list out other features of posterior cerebral artery occlusion. Okay, then see if you can answer this question. Okay, now regarding obstruction or occlusion of cerebral arteries, distal obstructions are more damaging than proximal ones. Now, I said the distal ones, which are beyond the subarachnoid space, which are in the substance of the brain, they don't have collateral circuit. They don't have anastomosis with other vessels. So they can be more dangerous than blocking an artery proximally. Okay, because you always get blood from the collateral supply. Then obstruction of the left side arteries is more symptomatic because in majority the dominant hemisphere is the left hemisphere. Okay, so that's why in our previous example also aphasia was there, because it's the left side of the brain that was affected. Okay, if it was the right side, you might not get aphasia because Wernicke's and Broca area are on the dominant hemisphere. Okay, so that's the true one. Then acute obstruction is more serious than gradual. It is true for even other vessels like coronary vessels. So if it is a sudden obstruction, even upper limb vessels, If there's a gradual obstruction, then your collateral circulations like your scapular anastomosis, elbow anastomosis, they have time to, other vessels have time to open up and compensate for the loss. So it's common for most of the places, not only the brain. Then striate arteries are the most commonly obstructed ones. Yes, true. Okay, it's the medial and lateral striate arteries of the middle cerebral that are most commonly obstructed and give rise to strokes. Then the anterior cerebral artery occlusion causes disconnection of the cerebral, yes, to some extent, because it supplies the corpus callosum. Because I told you at the beginning also, I showed you they lie very close to the corpus callosum and cingulate gyrus, and they supply the corpus callosum. So when the anterior cerebral is gone, left side of the brain and the right side of the brain, the connections are lost sometimes. So you get issues with the coordination of the two sides. Then the blood supply of the pons, medulla and cerebellum, we partly discussed this. We discussed about the superior cerebellar artery already, the anterior inferior cerebellar artery and the posterior inferior cerebellar artery. And I told you the reasons why we call them superior, anterior inferior and posterior inferior. So this one supply the superior surface, these two supply the inferior surface of the cerebellum. But the most important one out of these are, for our discussion, is the posterior inferior cerebellar artery, because that supplies the lateral surface of the lateral side of the medulla, and if that is obstructed, it gives rise to lateral medullary syndrome. Now this is a brainstem section which shows all the ascending and descending nerve tracts, and if you try to understand this diagram, this is the area for the pyramids. This is the area for the pyramids. So these are the pyramids in the medulla, and these are the inferior cerebellar peduncles. Inferior cerebellar peduncles going into the cerebellum. So this is the closed medulla actually, that contributes to form the fourth ventricle. That is the area of the fourth ventricle. And this medial lemniscus, by now you should know it, medial lemniscus, it is the posterior white column. Posterior column tracts going up after crossing. They cross in the lower medulla, the closed part of the medulla. Now this is the open part, closed part of, this is the open part of the medulla. So you have the crossed medial lemnisci, crossed fibers of the posterior white columns of the spinal cord. Vibration, position sense, fine touch, those things are taken in that. Okay, and this is, as I said, pyramidal tracts. Then here you see spinothalamic tracts. Spinothalamic tracts means the pain, temperature, pressure, crude touch, those things. Okay, then you have the spinal tract and nucleus of the trigeminal nerve. So again, you haven't done the trigeminal nerve. So that will take now from the trunk and limbs, you get pain, temperature through the spinothalamic tracts. From the face, you get from the trigeminal tract and the nucleus. But these ones are crossed ones. These ones are crossed ones. Already they have crossed by the time they reach that area. These ones are not crossed. These are uncrossed fibers. So you imagine, what happens, if you damage these with these together, you get the person like this with the trunk and all that. You get face, you get one side affected, trunk, you get the other side affected. Okay, I think we have discussed this partly when we did the nerve tracts. I showed you a lesion in the brain stem giving rise to same side face affected and the opposite side trunk affected. Okay, I showed you a diagram. Okay, so the same rule applies here. So this actually happens when you have a lesion in that area. Lesion in the sense you get lack of blood supply. Posterior inferior cerebellar artery occlusion, you get that side, that part of the medulla undergoing ischemic changes, so affecting these nerve tracts. You can see this nucleus ambiguous. Nucleus ambiguous, even though you have not done it yet, nucleus ambiguous is a common nucleus for 9, 10 and 11 cranial nerves. 9, 10, 11 cranial nerves which supply the muscles of the pharynx. So that is affected here. Pain and temperature from the same side and the opposite side of the trunk. Same side of the face and opposite side of the trunk will be affected, and because of the inferior cerebellar peduncle getting affected, you get definitely ataxia. Okay, and you can also see vestibular nuclei here. These are vestibular nuclei. Okay, these are vestibular nuclei. You can see the label here. So when the vestibular nuclei are affected, it affects the balance. Okay, because of that you get giddiness or vertigo, vomiting and all that. Okay, so because of this you get ataxia, because of this you get giddiness and vertigo and all that. Okay, so these are the tracts, actually these are the structures affected in lateral medullary syndrome when the posterior inferior cerebellar artery is occluded. Nucleus ambiguous. Okay, then the nucleus and the tract of the spinal trigeminal nerve, spinal lemniscus. Spinal lemniscus means the combination of anterior and lateral spinothalamic tracts, which takes pain, temperature, crude touch and pressure. Okay, so both are gone. Then the vestibular nuclei and the inferior cerebellar peduncle and the inferior surface of the cerebellum as well, because that supplies the inferior surface of the cerebellum, the same side. Okay, then what you could not see there was that the sympathetic nerve fibers, in that area you get descending sympathetic tracts coming from the hypothalamus or somewhere, which is going into the superior cervical ganglion. So the superior cervical ganglion is the one that supplies the head and neck with the sympathetic. Okay, so you get the sympathetic chains, upper end of the sympathetic chain, you get the superior cervical ganglion in the neck. So that gets upper motor neurons from higher centers coming. So these can get affected due to this lateral medullary syndrome. Now what this does is the superior cervical ganglion, it sends sympathetic fibers through the internal carotid artery into the head and mainly the head region. All your sympathetic going into the structures in the head are coming through the superior cervical ganglion. So what happens is, if again, if this is the face, if this is the face of the person, when you get superior cervical ganglion fibers affected, you get what is called Horner's syndrome. Horner's syndrome means you get lack of sympathetic supply to that side of the face. So if it is this side that is affected, you get reduced sweating, then the blood vessels get dilated because the sympathetic tone is gone. So you get redness in that area, sweating reduced, and at the same time you can get constriction of the pupil because the parasympathetic is not counteracted by sympathetic. You get constricted pupil. So these are some of the signs of Horner's syndrome. Okay, so superior cervical ganglion business is that. So these are the same list I have drawn with the symptoms or signs related to the effect on that structure. Now because of the effect on the nucleus ambiguous, you get dysphagia, difficulty in swallowing, dysarthria, issues with pronunciation or articulating words. That is due to nucleus ambiguous. If you want, you can read it even before the cranial nerve lectures. Okay, then the spinal, the trigeminal nerve and its tract, the same side, loss of pain and temperature sensations, as I said before. Then the spinal lemniscus is the contralateral loss of pain and temperature of the body and the limbs. Then the vestibular nuclei, vertigo, nausea, vomiting, cerebellum, it's the same side, gait and limb ataxia. Okay, anyways, ataxia. Then the descending sympathetic nerve tracts, as I told you, ipsilateral Horner's syndrome. Okay, try to go through this lecture. I will upload the PDF. Try to read this, go through this lecture carefully. Okay. Then there's another condition. Now the previous one was lateral medullary syndrome. There's another condition called medial medullary syndrome, not as common as lateral medullary syndrome, and that is due to vertebral artery occlusion. Okay, vertebral artery occlusion, roughly that is the area affected by medial medullary syndrome. Now you can see it's the pyramidal tract here affected. So these are fibers that are coming from the motor cortex. Okay, then you have the medial lemniscus, this posterior white column fibers. These are the ones that are affected, as well as you can see the hypoglossal nerve. This is the 12th cranial nerve coming out, that is also affected here. It passes through that area. So you get the same side tongue paralysis. So this is the pyramidal tract. You get opposite side hemiparesis. Why is that? Because this crossing takes place even below that. Now if this is your medulla, if your pyramidal tracts are like this, then the crossing takes place lower down here. Okay, now the section has been taken at a higher level. So they will cross here. So you get ipsilateral, not ipsilateral, contralateral hemiparesis. Then the medial lemniscus, it's medial, okay. Spellings has to be corrected. Medial lemniscus. Because of that, you get contralateral posterior white column, sensation loss, vibration, position sense, all that. Okay. Then the hypoglossal nerve affected, I said ipsilateral paralysis of the tongue muscles. Okay. Then the veins. Now the venous drainage we have already discussed, I think. Veins pass through the subarachnoid space like the arteries, and they cross the subdural space, subarachnoid space, then the subdural space somewhere here, and they drain into the dural venous sinuses. So most of the veins, they drain into the superior sagittal sinus as well as other sinuses as well. And we said when we discussed the hemorrhages, we said when they break in the subarachnoid subdural space, it can cause subdural hematomas, and these are called bridging veins. These are called bridging veins. They are the ones that break in the subdural space. Okay. And you know, and these dural venous sinuses we have already discussed. They lie between the endosteal layer and the meningeal layer of dura mater. Okay. And the names of different the venous sinuses, we have already gone through it. I will just show you some of them. So you have the superior sagittal sinus here. You have the inferior sagittal sinus in relation to the phalanx cerebri, upper border and the lower border of phalanx cerebri. Then you have this. Now this is the superior sagittal sinus. This is the inferior sagittal sinus. It drains into the straight sinus here. Okay. Then you have the transverse sinuses here. One going down is called the small one, occipital sinus. So the transverse sinus becomes the sigmoid sinus here, and at the jugular foramen here, the sigmoid sinus becomes the internal jugular internal jugular vein, and then you have this superior and inferior petrosal sinuses in relation to the petrous temporal bone, which drains the posterior part of the cavernous sinus. Okay, it's another important dural venous sinus. Cavernous sinus drains through these superior petrosal and inferior petrosal sinuses, and the cavernous sinus surrounds the pituitary gland here. It has the left side and a right side cavernous sinus, and a communicating part which is called the intercavernous sinus. Okay, so you have a right side, left side, and an intercavernous part. This is in the in relation to the sphenoid bone here, surrounding the pituitary gland. Then the cavernous sinus is actually, it has important connections with the veins of the orbit here through the ophthalmic veins. So if you get say thrombosis, infection of the cavernous sinus and thrombosis, you get swelling of the eye here. Okay, because of the venous drainage getting affected, ophthalmic veins drain into that part. Then similarly, when it comes to the venous drainage, another important thing, you can see the facial vein here. So this the deep facial vein, which drains the danger area of the face, upper lip, the tip of the nose, and this part of the face. This drains through the deep facial veins, which has communications with the pterygoid venous plexus. So these are the pterygoid area, the pterygoid muscles and all. The pterygoid venous plexus has a connection with the cavernous sinus through emissary veins in that area. So if you get infection of that area of the face, infection can spread through these veins into the pterygoid venous plexus, from that into the cavernous sinus, and you can get infection and thrombosis of the cavernous sinus, which is a very dangerous situation because certain cranial nerves are passing through the cavernous sinus, and that's very closely related to the pituitary gland and other parts of the brain. Okay, cavernous sinus thrombosis can be detected by effects on the eye, as I said before, swelling, pain, and all that. Okay, so the same thing. So this dural venous sinuses learned them in relation to the falx cerebri and the tentorium cerebelli as well. Okay. Then the blood supply of the spinal cord. Now, we said the vertebral arteries, they give rise to the anterior spinal artery here. Okay. So the two branches coming from the two vertebral arteries form one artery with the anterior spinal artery. Then there are two posterior spinal arteries starting from the posterior inferior cerebellar arteries in the other direction. Okay, I cannot draw it in the other direction, lower down. Okay. So then you take the spinal cord. If this is your spinal cord, okay, you get it like this. You get one anterior spinal artery and two posterior spinal arteries. So two posterior spinal arteries arise from the posterior inferior cerebellar artery, as I said before, and even though there are two arteries, the area supplied by them are much smaller compared to the area supplied by the anterior spinal artery. It's only 1/3 of the spinal cord. It's only 1/3. I should have kept the diagram. So if I draw it like this, so it's roughly, that area is supplied by the two posterior cerebral arteries, posterior spinal arteries, and this whole area is supplied by that is 2/3 supplied by the anterior spinal artery. Okay. So all your nerve tracts except the posterior white column tracts can be affected if you damage the anterior spinal artery. We'll take a look at towards the end. Then other than the anterior and posterior spinal arteries, there is another type of arteries which are called the segmental spinal arteries. Segmental spinal arteries, and the segmental spinal arteries, they enter the vertebral canal to supply the spinal cord through the intervertebral foramina, where the spinal nerves come out. Intervertebral foramina. Okay, and immediately after they enter the vertebral canal, they divide into an anterior and posterior radicular arteries. Radicular means that they actually follow the anterior and posterior roots of the spinal nerve. That's why the arteries are called radicular. I'll show you. Okay, now this is that. So you get this spinal nerve here passing through the intervertebral foramen here. This is the segmental spinal artery entering the vertebral canal through the same space and dividing into anterior and posterior radicular arteries, which follow the anterior and posterior nerve roots of the spinal nerve. Anterior and posterior roots of the spinal nerve. And these arteries actually become an important source of blood supply to the spinal cord. Now, why is that? Because even though you have this anterior spinal artery and the posterior spinal arteries supplying the whole spinal cord. Now we said anterior spinal supplies anterior 2/3 and the posterior spinal artery supplies posterior 1/3. Now that is true for the cervical segment of the cervical part of the spinal cord. After the cervical part, in the upper thoracic and below, these spinal anterior and posterior spinal arteries become smaller and smaller, and they cannot supply they are not sufficient to supply the whole spinal cord. Therefore, these segmental spinal arteries that we discussed here becomes more and more important when it comes to the lower parts of the supply of the lower part of the spinal cord. Now, in the cervical, if you block the main anterior spinal artery or posterior spinal artery, you will have main effects on the cervical segment of the spinal cord. If you block these arteries in the thoracic area, lower down, you might not have a serious effect. Okay, so remember that point as well. Then other than this segmental spinal arteries, there are additional feeder arteries, arteries that feed. Feeder arteries means they feed blood. Feeder arteries are helping to supply the spinal cord. Now one such artery that is important over the other arteries is this special artery, which is called great anterior medullary artery of Adam's kiwi. I don't know how to pronounce it. Adam's kiwi. Now, not only that, there are other additional feeder arteries which are direct branches from the abdominal aorta. Therefore, the importance of anterior and posterior spinal arteries become less and less when it comes to the thoracic and lumbar areas. But in the cervical area, they may be important. Then when it comes to the venous drainage, there are anterior and posterior spinal veins. Just, they are just like arteries. You have anterior and posterior spinal veins. They all ultimately drain into a vertebral venous plexus, which is called the internal vertebral venous plexus. Now, they are called internal because they lie inside the vertebral canal. But outside the spinal cord. The spinal cord is like that. The dural venous sinus lies between the spinal cord and the vertebral, the bone, and they actually lie in the epidural space. Remember that. Epidural space is another name for extradural space. So this is your durameter. Now this is your arachnoid mater and pia mater. So the spinal arteries, they lie in relation to the spinal cord, very closely related, but they drain into this internal vertebral venous plexus lying in the epidural space, okay, outside the durameter. Now this is the point that I wanted to highlight. If you obstruct the anterior spinal artery high up in relation to the spinal cord, you can actually have bilateral loss of motor function due to damage to the corticospinal tracts and anterior gray horns both, okay, because all that area is supplied by the anterior cerebral artery. Then you can have bilateral thermoanesthesia, analgesia due to damage to spinothalamic tracts, these ones, and loss of bladder bowel control due to damage to the descending autonomic, because in that area, I said sympathetic and parasympathetic descending tracts are coming, they are affected. Therefore you get effects on the control of the bladder and bowel control. Then posterior column, the posterior columns are intact, so vibration, fine touch, position sense, they are normal. So they are the ones that are affected bilaterally if you damage the posterior, if you block the posterior inferior posterior spinal arteries, okay. But since there are two arteries, it's unlikely that you will block both at the same time, so you will block only one side. So then you will get based on the block, you will get contralateral loss of vibration, fine touch and position sense.